Smith French Laboratories is pleased to bring you this ongoing series of highlights from the 7th Annual Vail Conference of the Menninger Foundation. Update on schizophrenia. Dr. Michael H. Stone begins this program with a discussion of individual psychotherapy with schizophrenics. Dr. Stone is professor of psychiatry at Mount Sinai School of Medicine in New York City. First, here's a brief message from Smith French Laboratories and SK&F Co.
The human touch, sound of the human voice, understanding, warmth, reality. When your chronic schizophrenic patient suddenly, perhaps violently, loses touch, the potent action of non-addictive stelazine injection promptly reduces hallucinations, delusions, and other core psychotic symptoms. With these disruptive symptoms under control, the wide variety of stelazine dosage forms and strengths enables you to easily make the transition from intramuscular to oral dosing for effective maintenance therapy. You will be pleased to see that stelazine maintains your chronic schizophrenic patient through effective control of psychotic target symptoms. And since, as you know, stelazine apparently activates withdrawn, apathetic, or detached patients, you have a greater opportunity to reach your patient with other forms of therapy. Your patient suffers less, responds faster. In addition, stelazine offers these treatment benefits. Stelazine seldom causes excessive sedation. Stelazine demonstrates a low risk of anticholinergic effects and orthostatic hypotension. Stelazine offers convenient, economical BID dosage. And while stelazine shares the increased risk of extrapyramidal symptoms associated with all high-potency neuroleptics, when encountered, these symptoms are generally readily controlled. We urge you to prescribe prompt-acting non-addictive stelazine for your chronic schizophrenic patients because the way back begins with the human touch, sound of the human voice, understanding, warmth, reality, because the way back begins with your healing touch.
Stelazine is contraindicated in comatose or greatly depressed states due to CNS depressants, in cases of existing blood dyscrasias, bone marrow depression, and pre-existing liver damage. Avoid using in patients hypersensitive to phenothiazines. Physicians should be alert for neuromuscular reactions such as pseudoparkinsonism, potentially irreversible tardive dyskinesia, and other adverse effects associated with phenothiazine therapy. Patients with a history of long-term therapy with stelazine and or other neuroleptics should be evaluated periodically to decide whether the maintenance dosage could be lowered or drug therapy discontinued. Before prescribing stelazine, please consult the accompanying booklet for complete product information, including additional warnings, precautions, and adverse reactions. Be sure you're the doctor. Always write stelazine D-A-W. Dispense as written. Now here is Dr. Michael H. Stone with highlights from his talk on individual psychotherapy with schizophrenics.
In the current decade, the first sophisticated study of follow-up in a schizophrenic sample diagnosed according to contemporary standards who were at the same time chosen as well as can be for expressive therapy and treated by experienced therapists over a long time was reported recently by McGlashan out of Chestnut Lodge. These were in the main middle to upper class patients of average or better than average intelligence. This was not the disadvantaged population seen at Camarillo State as in Philip May's study. Nevertheless, the schizophrenics, in comparison with the unipolar depressives, many of whom were DSM borderlines as well, and bipolar patients, had fared poorly, exceptional cases aside, leading marginal existences, often enough spared a still worse fate owing to the lack of family money and family support well into adult life. Their average global assessment score, which of course is similar to the Menninger score, you'll have to forgive me, in New York we tend to use Spitzer's revision of it more than the Luborsky score, but anyway, same 100-point anchored rating scale and very reliable, easy to agree within 5 points between colleagues and so on. The average score was in the mid-40s, which is compatible with marginal function. McGlashan's work motivated me to compare the outcomes of schizophrenic patients treated on the long-term intensive psychotherapy service at New York State Psychiatric Institute from 10 to 20 years ago with the Chestnut Lodge group. I undertook to ascertain outcome results in patients screened and accepted for insight-oriented psychotherapy at Psychiatric Institute. I selected for study the 14 cohorts of patients during the years 63 through 76. These years span the time of my residency training, my years of supervision by Searles of a portion of these patients, my years as an attending, and for a while acting chief of this long-term service, which toward the end Otto Kernberg assumed the directorship of between 74 and 76. Because of my almost continuous involvement with this service and my acquaintance with almost every resident therapist to pass through it, I knew with few exceptions all the patients and all their therapists personally. This put me in a unique position to contact all the 563 patients who remained on the unit 3 months or more, which I used as a cutoff point for long-term therapy. Most of them were well in excess of that, and 180 therapists. Patients were selected for supposed amenability to expressive therapy largely by clinical gefühl. The directors on either side of my directorship were Alvin Politan, Mesnikoff, Lothar Gudro-Frank, and Otto Kernberg. The ratio of borderline level to psychotic level patients was approximately 3 to 2. The male-female ratio was at parity in this whole group. Of course, the borderlines were predominantly female. Schizophrenics and severe obsessive character disorders were overrepresented among the males. The group was young, average age 22, almost all white, middle to upper middle class, and had an average verbal IQ of 118, which I think is pretty much the same number that McGlashan found and that Gunderson had in the Boston study at McLean's. I have traced the patients through their therapists, many of whom have continued to work with their residency day patients over the ensuing years, as I have myself. In addition, I have contacted many of the patients who, as it happens, tend to maintain their ties with their dormitory mates over the years, considering themselves, not without justification, as graduates of PI. Thus far, in the still early stages of this undertaking, I have traced 38% of the sample, some 210 patients, where I have been able to obtain sufficient data to register, among other things, a latest GAS score. I have, wherever possible, recorded marital work and friendship states along with data about rehospitalizations, medications, and so forth. I have ascertained that 30 of the patients suicided. 21 of these were among the initially psychotic group, 9 in the borderlines. The suicide rates are not very meaningful at this time because I heard about several over the past few years via the hospital grapevine, since the news of such tragedies spreads faster than news of success stories. For what it is worth, the suicide rate breaks down to 27% in the 44 core schizophrenics and 30 in the 10 schizoaffectives so far traced. There were no suicides among the few schizophreniform or acute schizophrenic and bipolar patients, but the latter were rarely admitted for long-term psychotherapy, so that's a small group. Most of the schizophrenic suicides were in non-drug abusing patients, in contrast to the borderline group where drug abuse was an important concomitant among the 9 suicides I have traced in this larger group. I traced 100 borderlines so far. The average global assessment score in the still alive, unequivocal schizophrenics was 39.1 with a range of 15 to 66. In the still alive schizoaffective schizophrenics, the average global assessment score is 52.3, compatible with getting along, but with pretty clear-cut symptoms that any clinician would think required some attention. The acute schizophrenic patients, who would not even be considered as examples of the schizophrenia spectrum by Ketty, showed an average global assessment score of 69.5, but there were only 5 such patients in the study that I could trace so far. This dismal outcome of the schizophrenics could not be written off to intellectual differences from them in the borderlines, because the average verbal IQ in the still alive schizophrenics was 116.2, and in the schizophrenic suicides it was even higher, 127.6. What is noteworthy about the schizophrenic suicides is mostly their striking manifestation of the so-called negative symptoms of anhedonia, apathy, and emotional constriction. Quite a few were unusually intelligent males whose severe emotional handicaps made them feel hopelessly unable to compete with their often highly accomplished sibs and parents. Overwhelmed by the glaring and seemingly irremediable contrast, they took their own lives, acts to which they were particularly vulnerable at times of separation from a vacation of their therapist. Dr. So-and-so leaves the service, so-and-so goes out and takes a shotgun and blows his brains out. That happened not in every case, but in an alarming percentage of them. This is a group that often couldn't say anything about the feelings that were stirred up in them by the impending separation, that denied that the therapist meant anything to them, and the therapist often tended to underplay the degree to which their existence even mattered to the patient at all. In the main, we tried to take the situation seriously and oftentimes tell the patient that we thought that they must be showing some reaction, that they were going to take it hard. When we were about to go on vacation, the patient would often poo-poo it. We would often put them in more close observation and things like that, so that it wasn't as if this was all happening in a state of ignorance about the possibility of that impact, but even so, these tragedies occurred with this rather depressing regularity. The best outcomes now in the hospitalized schizophrenics. There were 4 patients in the unequivocally schizophrenic group, that's unequivocal by contemporary diagnostic standards, whose global assessment scores 10 to 15 years after discharge were 55 or higher. 2 seemed to improve through what McGlashan and Carpenter have called sealing over, while 2 seemed able to integrate the clarifications and interpretations offered them within the context of a therapy where supportive and expressive techniques were judiciously balanced. One man, now in his late 30s, lives a relatively isolated life, though he sees some friends, dates, has sexual relations occasionally. He works full-time in a publishing house as an administrative assistant. In his sessions with the same therapist he's been working with since he was an inpatient, he continues to deal with themes of bitterness about his illness and about the low ceiling of achievement it seems to impose on him in comparison to his very accomplished parents and sibs. Another man, also in his late 30s, is about to marry and has lately held a full-time job commensurate with his master's degree, though for 8 years after discharge he could perform only simple occupations which were not so simple for him because of lingering concerns about being taken advantage of by his co-workers. Therapy for this patient, too, has become increasingly expressive in nature as his successes have enabled him more and more to look back with less humiliation and fright at the events of his early years. 2 other best outcome schizophrenic patients appeared to improve largely by process of sealing over. Both were girls in their late adolescence when admitted. One was considered prognostically to be beyond therapy or hope. The patient was given a global assessment score of 5 on admission, the lowest ever recorded by the staff for a newly admitted and still alive patient. Because of her frantic suicide attempts by whatever means lay at hand and by her grotesque bulimia, in which she ate refuse from garbage pails as though that were all she deserved. During the 7 months she spent on the unit, a modest time span for that unit, she gradually sealed over. She never showed any motivation or capacity to deal candidly with the truly nightmarish events of her life at home, about which it may be fair to say that one could scarcely expect a young person of her emotional fragility and only meager appearing personal assets, intelligence and training and whatnot, to deal with any more openly. Still unnerved by the prospects of contact with her original family, she restricts social relationships to safe people. She maintains a treatment relationship with a therapist whom she sees about once a month or as needed. The other adolescent was less ill at outset, having made a few superficial suicidal gestures, but never indulging in the grotesque behavior of the preceding patient. In the 10 years since her discharge, she is married, having found a tender and protective husband, and leads a comfortable, if rather sheltered life with him and their 1 child. She pursues her artistic talents and has decorated their house with her paintings. Her global assessment score has risen from its initial 15 to its current 62. For core schizophrenics, the era of purely exploratory therapy, I think, is probably drawing to a close. From a purely practical standpoint, that is understandable because there is not much evidence of its efficacy in this patient population. This is so even if one turns one's attentions to the studies where the schizophrenics given this therapy were young, brighter than average, and from more favored socioeconomic classes, as in McGlashan's study, Gunderson's schizophrenia studied by two different randomized to either exploratory or treatment as usual. The Gunderson study showed disappointing results in the sense that the schizophrenics were not doing particularly well several years later, although they started out with the kinds of advantages I've just been mentioning. They were as promising a group of schizophrenics as one could amass in any large center. The core schizophrenics on the long-term service at PI had poor outcomes on average, as had the Chestnut Lodge sample. Since many of these patients even had experienced therapists at McLean's and at the Lodge, not all the failure to improve can be ascribed to inexperienced therapists by any means. The personality profile is of critical importance in predicting outcome as well as response to exploratory therapy. The distribution of personality types, predominant and secondary, is of course different in a population of schizophrenics from what one would find in a sample of manic depressives or of neurotic patients. Perhaps 25% of schizophrenics, that's Arietti's estimate and Bellack's, are premorbidly schizoid, whereas schizoid personality is not nearly so common in the general population, and it is quite rare in manic depressives. The Kraepelinian temperaments, depressive, irritable, manic, and cyclothymic, are peculiar to manic depression and are scarcely at all seen in schizophrenia. Paranoids are common in both groups. Paranoid really does not discriminate for schizophrenia, as people used to think. You'd hear the word paranoid and you'd think schizophrenic. I'm sure we're all beyond that level of thinking now. My impression is that the degree or the intensity of paranoid traits varies inversely with amenability to psychotherapy. The same might be said of narcissistic traits, such as exploitativeness and contemptuousness. The more marked these qualities, the worse the prognosis and the worse the chances of success in an exploratory approach. The qualities that make up what we loosely refer to as likableness correlate well with prognosis and amenability to psychotherapy. Therapists who are inclined to shy away from such pronouncements on the grounds that they appear too much like value judgments or ethically questionable remarks may opt to do battle with me on this point, but I doubt if they could disprove the validity of the observation. And I'm reminded in this connection with a story that I often tell about an analyst that I ran into, a Mexican psychoanalyst, and I was just beginning my training at Columbia Psychoanalytic in New York, so I was full of wanting to talk about criteria for analyzability and all this kind of thing. And so I asked him, well, what do you use down in Mexico for choosing which patients to analyze and which ones you don't? Figuring he'd give me some careful stuff about motivation and certain personality factors and what have you. He said, well, if we like them, we analyze them. And if we don't, we don't. I remember dismissing that as like, what a superficial, dumb remark, But then over the years, as I think back on that, it occurs to me that as uncomfortable as it may seem, he was really onto something. That whatever it is that goes to make up the quality of likableness seems to correlate very highly with amenability to psychotherapy, to say nothing of exploratory psychotherapy. Certainly one has to have an ability to resonate with the feelings of others in order to be liked by others. A certain quality of respectfulness, for the effort that the therapist is putting in, which makes the therapist glow, as though he's being useful. That helps. Persons who try very hard to get better, meaning who take their problems seriously, affect one and have sown the seeds of likableness, if you will, in contrast to people who have a devil-may-care attitude and a contempt for their own problems and also for your efforts to do anything about them. So it's not surprising that this one item correlates very strongly, I think, with outcome, good outcome, and with amenability to treatment, even though it seems sort of unscientific and a little bit irregular. Schizophrenics, more than other types of patients, are prone to eccentricity. This is in fact a hallmark of their condition, and to misinterpretation of what is meant. They are more apt to remain insensitive to various social cues in such a way as to offend others, even inadvertently. They may dress inappropriately for work or social occasions, maintain a poor hygiene that alienates co-workers, or potential friends, and so forth. Some are eager to learn how better to fit in. This augurs well for outcome, but others are militant in their unconventionality. Even though we can grasp the dynamics, we may be powerless to effect much change. The patient may prefer to be rejected by others for selling bad than for being an odd duck, since the former seems less personal, more under control, and further away from the patient's sense of his core self. Similarly, some patients prefer to read a suitor's rejection as prompted by a negative reaction to a peculiarity of nose or cheekbone than to having a difficult personality. One is not responsible for one's physiognomy. Patients who take refuge in excuses of this kind, and many schizophrenics do, may present intractable problems in therapy. Eccentricities may involve thought or behavior or emotional reaction, peculiar beliefs, food fetishes, insensitive behavior when visiting friends, smiling at news of personal tragedy, and whatnot. These qualities may not necessarily defeat therapy, but if pronounced, they necessitate a large-scale re-educational or behavioral modification program that then becomes a supplement to the dietic therapy. Patients find it humiliating to be told that they are more offensive and peculiar than they are acceptable. So schizophrenics who are, so to speak, more than half in need of such criticism and re-education may find therapy too painful and may quit, or else make it plain that those areas are off limits. All things being equal, it goes without saying that a supportive and cooperative family may help a therapist salvage an unpromising treatment situation, while an openly destructive and uncooperative family may scuttle a hopeful situation. Schizophrenics are especially vulnerable to these influences because they are so often very dependent upon their families for a longer period and in more extensive ways than other patients. The term borderline schizophrenic or schizotypal personality is used by Eckstein, Rotto, Neal, Keddy, DSM-3, happens to stake out a territory of patients, only a few of whom have reached the Kernberg borderline level. The rest are, in object relations, psychostructural terms, still on the psychotic level, even though not chronically diluted like the unequivocal schizophrenic, the patient. With the psychotic level borderline schizophrenic, one often feels tempted to use an exploratory method, especially if the patient is highly intelligent and has some intellectual insight into his condition. But usually one finds that the distortions and misperceptions in the images of self and of the important others are more severe and inflexible than the therapist had anticipated. The exploratory method, if relentlessly pursued, will either alienate the patient so that he quits, make the patient feel worse, or else lead to endless interchange of deep-sounding pseudo-insights that fail to nudge the patient toward health. In the higher level of borderline schizophrenics, as Meister refers to them, the exploratory method can often be useful, though will tend to be admixed periodically with supportive interventions. The cases that turn out well are often mentioned in the analytic literature devoted to the topic of the analytically oriented therapy with schizophrenics. Reading about these good outcome or otherwise fascinating cases of Bryce Boyer, Searle, Gilbertini, Semrad, Otto Will, Lewis Hill, and so on, sometimes inspires the inexperienced to try their hand at it in cases that were not optimally or wisely chosen for this method. The essential difference between the schizotype and the affected patient is schizotype misinterprets because of the cognitive distortion, whereas the affected person often interprets correctly, but either turns up or turns down the gain and either overreacts or underreacts. The manic typically overreacts. Is irritable, is hypersexual, tends to adore, tends to hate, and all the rest of it. The depressive person sees himself as terrible. Any little fault is magnified. So the affected person will have the task of minifying the excessive amplitude of their reaction, whereas with the schizotype, we're constantly bringing them back onto the middle line as they tend to veer off into a distortion because of their tendency to misperceive. Ego boundary problems crop up much more naturally with schizotypals than with affectively ill people and need our attention. There's a lot of need with the schizotype to integrate within the framework of an exploratory therapy, re-education, behavioral modification, and other techniques which answer to those problems which cannot be answered really by
an exploration of the past and a correlation between the dynamic past and the present of the patient. As a final note concerning prognosis in patients with schizotypal personality attributes one's general character are critical factors. Even where some of the schizotypal features may be quite prominent, a capacity for respecting others, for compassion and empathy, will go far to mitigate the effects and otherwise alienating peculiarities of all their behavior, and tend to offset the gloomy predictions one might have made were ones who have dwelt solely on conventional measures of psychopathology.
Christine McGill, MSW, continues now with highlights from her discussion of the Psychosocial Therapy of Schizophrenia. Ms. McGill is Assistant Clinical Professor of Psychiatry at the University of California at San Francisco School of Medicine. Now, here is Ms. McGill.
Basically, the concept of expressed emotion, EE, developed out of some interesting research that was done in England in the late 1950s by George Brown and John Wing. And what they were attempting to determine is what were the factors, the environmental factors which contributed to a patient's positive or negative outcome when returning to the community from hospital. And after doing extensive interviews with family members and community caregivers, what they came up with was the notion that the amount of criticality, over-involvement, and hostility in the patient's immediate environment had a direct impact on whether that person returned to hospital or relapsed in the 9-month period following community placement. In an environment where there was low EE and not as much stress on the patient, the relapse rate was significantly lower. Now, the important thing about this notion of expressed emotion is that its predictive validity has continued to be quite robust. There have been 3 similar replications of the earlier work. The most recent one conducted at Camarillo with an American cohort of schizophrenics. And what's quite remarkable is that in all these studies, the relapse rate on the high expressed emotion group has fluctuated between 51 and 57%. So it continues to be a highly predictive index of relapse. I'm sure some of you are wondering how is a rating of expressed emotion made. And it is a very complex coding system. It is a research diagnostic interview where a clinician sits down with a family member at the time that the patient is hospitalized, at the time of crisis, and asks the family informant to provide information on the patient's symptom picture, the patient's social functioning, the patient's daily living habits, basically what has been going on in the period preceding hospitalization. And on the basis of that interview, which usually takes about an hour and a half, there are actual ratings, frequency counts, and other scales to determine whether that family is a high expressed emotion family or a low expressed emotion family. With a rating of high EE, and particularly with a rating of high EE in both parents or in multiple family members, that becomes a high-risk marker for potential relapse of that patient returning home to the family. Now, in addition, there have been other factors which have been identified as important in either modifying the relapse rate or contributing to the relapse rate. One of those is neuroptic maintenance, and another is the amount of direct face-to-face contact that the patient spends with the high EE family members. In terms of intrusiveness and over-involved behavior, there's a real lack of regard for boundary space in high EE parents. In low EE parents, there's much more acknowledgement of generational boundaries and need for personal space. In terms of emotional response, a high EE parent is much more likely to become very, very upset, very distressed, angry, hostile, rejecting, and to verbalize this, at least on interview. Whereas low EE family members tend to stay more calm and are more accepting of crisis situations. In terms of attitude toward the illness, which I think is a key factor that we're trying to get at with the educational intervention, there is a genuine doubting of the validity of the illness on the part of a lot of high EE families, or a misattribution of illness to some other factor. Low EE family members are more likely to acknowledge that there is an illness process going on and that the patient is currently not in their normal state. Expressed emotion can be construed to be ambient family tension. And so the idea is that in families where there is a high level of stress already, their ability to cope with other unanticipated events is perhaps lessened. This makes the person with schizophrenia much more likely to be over the threshold of tolerance of the pressure of the environment and more susceptible to relapse. So really what we're trying to do is to lower the expressed emotion, the ambient tension, the other stresses within the family over which they have some control, so that they're better able to cope with the other environmental stresses and also less likely to induce a relapse in a vulnerable member. Another important thing is general systems theory and really looking for just what is the person's and the family's support system in a community, in a treatment setting. And this is very, very important, particularly given the fact that we know that a lot of these families are very socially isolated and don't have much external contact, don't have much networking, and are dealing with the enormous burden of caring for their mentally ill member basically on their own with very little help from even from mental health professionals. The combination of life stress, life events, can really only be modified by enhancing the family's coping mechanisms, giving them support, giving them psychosocial intervention, and neuroleptic maintenance to really prevent the prodromal signs of impending relapse from returning, fluid relapse.
This concludes the remarks of Ms. Christine McGill. Please turn the cassette over for Dr. Michael H. Stone's discussion of individual psychotherapy with borderlines.
Our program continues with highlights of Dr. Michael H. Stone's remarks on individual psychotherapy with borderlines, after this brief message from Smith, Kline and French Laboratories.
The fragile shell of the borderline patient. Like the shell of an egg, it may be seamless, secure.
Your borderline patients may manage a career, family relationships, rewarding friendships, until the pressure builds. Pressure to the point of overwhelming stress.
Then the fragile shell may crack. Psychotic symptoms emerge.
You can help return your borderline patients to reality by controlling emerging psychotic symptoms with the short-term use of non-addictive stelazine, brand of trifluoroperazine hydrochloride. And because stelazine seldom causes excessive sedation, your patients will remain more alert to other forms of therapy. Stelazine offers a convenient, economical BID dosage regimen that helps ensure compliance.
When the fragile shell of the borderline patient cracks, remember, stelazine controls occasional psychotic symptoms.
Stelazine is contraindicated in comatose or greatly depressed states due to CNS depressants, in cases of existing blood dyscrasias, bone marrow depression, and pre-existing liver damage. Avoid using in patients hypersensitive to phenothiazines. Physicians should be alert for neuromuscular reactions, such as pseudo-Parkinsonism, tardive dyskinesia, and other adverse effects associated with phenothiazine therapy. Patients with a history of long-term therapy with stelazine and/or other neuroleptics should be evaluated periodically to decide whether the maintenance dosage could be lowered or drug therapy discontinued. Before prescribing stelazine, please consult the accompanying booklet for complete product information, including additional warnings, precautions, and adverse reactions. Be sure you're the doctor. Always write stelazine DAW. Dispense as written. Now, here is Dr. Michael H. Stone.
One of the difficulties in approaching the borderline problem conceptually in psychiatry stems from the habitual reification of the tentative notions we begin to formulate, and from a parallel tendency to confuse substantive with substance. There would appear to be an essence of schizophrenia. In its most extreme form, schizophrenia is an aberrant human condition that does not so much break laws the rest of us obey as it does travel along a separate path, creating humanoids inhabited by body snatchers who follow rules quite different from ours. The word borderline is different. It does not correspond to a thing in nature that stands apart like schizophrenia or the tubercle bacillus. awaiting some clever person to verify through external means of validation. Borderline is rather a construct of utility, of convenience, an assemblage of signs, symptoms, traits, attributes that serve us well today but could easily be replaced by a still cleverer collection of qualities tomorrow, and has been a number of times, as we've seen, over the last century. For this reason, I tend to wince when I hear clinicians say borderlines have inordinate cravings or borderlines act out, because in the evolution of this diagnostic label, it is precisely the craving and the impulsivity of some adolescents of the 30s and 40s to say, let's take these sicker-than-usual neurotics who are so demanding and needy and impulse-ridden and set them apart as limiting cases of the efficacy of our new method. We will dub them borderline. The other side of the coin of this craving is irritability. Let us, in other words, pay attention to certain persons who test reality well enough, who have an enfeebled sense of self and a contradictory sense of what other people are all about, and in addition are inordinately restless. These persons we will call borderline. The restlessness must be associated with an abnormal craving that needs repeated doses of something out of the ordinary to calm it temporarily. The most obvious subtypes concern substance abuse. Alcohol is craved by those we come to call alcoholics. Others crave sleeping pills or stimulants or drugs that take them outside the realm of ordinary life and ordinary logic, the psychedelic substances. Whatever definition of borderline people have come up with, it turns out that substance craving is a common attribute, so much so as to threaten to engulf other symptoms and supersede them in clinical importance. If this happens, opinion divides currently as to whether it is more useful to keep on referring to such patients as borderlines who happen to abuse this or that substance, or, as Gunderson prefers, to abandon the borderline diagnosis wherever this substance becomes center stage, and to rename the patient simply alcoholic or drug abusing or whatever. In the area of sex, craving shows up as Don Juanism, promiscuity, including the compulsive brief encounters in subways of certain homosexuals and so forth, hypersexuality, and of desperate love if the latter is part of a repetitive pattern of masochistic object choices, and is accompanied by endless adoration and an inability to be apart even for a moment. The latter may be seen as possessiveness, which may not involve sexual aberration simultaneously, but which almost surely serves as an antidote to the inordinate anxiety certain people, borderline people, experience when alone. Misers, gamblers, people that are consumed with religious fervor, people who indulge in petty crimes like shoplifting are also prone to exhibiting the rest of the characteristics we labeled borderline, at least by broad criteria. I have noticed over the years that one pattern capable, when taking shape in early childhood, of setting in motion abnormal craving in the sexual realm is incest. Incest victims are far more apt to be women than men. They are found with particular frequency among hospitalized borderline women. Chronic victimization, especially by an older man, especially by the father, sets up a pattern of excitation at a time when habits acquire lifelong force that can never be overcome. In such persons, mistrust is bred along with craving, outrage side by side with adoration, all of which leads in adult life to serious disturbances in close relationships, serious disturbances in the image of self and other, which is the very thing that Kernberg describes as characteristic of the borderline level, and often leads to pathological jealousy as a particular syndrome. When I did a study of that at Westchester Division, I found that 75% of the borderline girls had had some degree of incest broadly defined, not necessarily with orgasmic sex or nudity on both parts, but some form of obvious seduction and sexual play. That seemed like a preposterous figure, which is supposed not to be able to happen very often. So I thought, well, it's intriguing, but I'm not going to believe this. I'm going to try to get a bigger series. I went to Seattle and gave a talk there, and one of the people there had looked at the rate of incest broadly defined in his borderline hospitalized girls and said, well, in our series it's 90. At that point, I think you have to take a step back and realize that you're in the presence of a factor of such importance and which has been so neglected, that it really helps account for a lot of the variance in the lopsided ratio of males to females in any borderline sample in this country or in most of Europe, namely that there are 2 or 3 females to 1 male. The tendency toward depression, which is more marked in females than in males, accounts for some of it, because then the attenuated forms of depression end up as our unstable type borderline. But accounting for this lopsided ratio, I think, comes from the incest factor, because chronic victimization can bring about the disturbances in impulse and the disturbances in the views of others and oneself, which are the very thing that we then call borderline by Krimber criteria, and they often have disturbances in close relationships, intolerance of being alone, chronic feelings of emptiness, lability of affect, intense inordinate anger. In other words, they have DSM borderline features as well. The challenges confronting analytically oriented therapists of borderline-level patients are in some respects alike for both schizotypal and the affective patients, and in other respects different. All those near the edge of treatability need to work with therapists who can inspire hope. But this can only come about if the therapist's hope is genuine. And that will only come about if something from within the patient stimulates, for equally genuine reasons, a spark of hope in the therapist. The balance between life assets and liabilities is a key issue in treatability. The family background colors the patient's perception of himself and thus exerts its own impact on this balance. Thus, a constitutionally handicapped patient would feel worse about his meager achievements having come from a family of unusually competent people than he would have had his parents been of average endowments and accomplishments. It is part of the therapist's task in any case to assess the patient's strengths so as to be ready to help him capitalize on whichever one seems easiest to mobilize. Some patients will be nearer to work resumption than to movement toward establishing friendships. This is often so with schizotypals. Others can form a love relationship far in advance of being able to work. Whatever function the therapist can help his patient resume, however, becomes part of a positive feedback system that bolsters self-confidence and facilitates movement into other formerly avoided areas. In patients given to suicide gestures, these small steps toward maturation in time tip the balance toward hopefulness and thus reduce the risk of self-injury. Schizotypal patients often need special attention to difficulties in resonating empathically with others. This will less often be true of the DSM borderlines, who in contrast need greater attention to their impulsivity and demandingness. They tend to be unreasonable, whilst the schizotypes tend to be unmovable. Schizotypes often require a kind of re-education about the intentions of other people. This type of supportive therapy is not so often necessary with unstable borderlines. The latter, however, may require a different sort of support alongside the expressive interventions in the form of specific programs for help with the substance abuse or eating disorders, the craving, in other words, to which they are more susceptible than schizotypes. The experience of any one therapist, however systematically codified, cannot supply complete answers regarding prognosis in the just treatable borderline patients. Clearly, some will fail with one therapist, succeed with another, and would thus be falsely counted as poor outcome patients if viewed from the narrow perspective of the first therapist. Long-term studies of outcomes, such as that recently reported by McGlashan, will be instrumental in determining the success-failure ratio in the group as a whole. Further analysis of the characteristics of the good versus poor outcome patients will in turn increase our understanding of the characteristics that will help us select at the outset the patients best suited for intensive psychotherapy. In borderline patients, you don't have the ability really to fall back on the old analytical model of waiting for the patient to say something, because the patient may be too charged up with hideously uncomfortable feelings and the feeling that you're going to reject him if he really says what the truth is. So you have to figure out what the patient is probably struggling with and to say it in such a way as to make the patient know that that topic doesn't lead to feelings of disapproval in you, such as one woman who was having marital difficulties, was hospitalized in Connecticut, couldn't tell her husband what was bothering her, but as a result she was often anxious and he didn't know what was bothering her, and so he began to think of her as kind of an odd and difficult person, and there was a lot of strain in the marriage. What had happened was that she had an unusual background, which I'll get to in a moment, but she would get to a certain point in the dialogue with me, and she would suddenly become silent. And I would say, well, what comes to mind? Well, I can't tell you. I can't tell you. So I said, well, when you say you can't tell me, right away, I think of what are the list of things that people can't tell a doctor. First of all, there's the history of incest. Second of all, there's the history of being abandoned on the high road. Third of all, there's being cudgeled, by a parent. And I said, no, those are the kind of things that people can't talk about. So that in telling me that you can't talk about it, you've already narrowed the field down to 3 topics. At that point, she says, well, as a matter of fact, I happened to think that it was an incestuous relationship with a male relative. Her mother beat her senseless when she was little, knocked her out several times, broke several ribs, alcoholic mother, this kind of thing happened frequently, and she was terribly ashamed to talk about that lest her husband think that she came from a crazy family, which indeed she had, and therefore think less of her or begin to suspect that she could go the same way. And for want of being able to talk about it, she was frequently in situations where she would get extremely anxious about something other people wouldn't get anxious about. Her husband wouldn't understand where she was coming from, and she couldn't talk about it. But when I said for her what it was, and could say it with a matter-of-fact tone of voice like, well, what else is new? It took away the fear that she had that the other person would reject her. So we need to do that kind of thing very often in dealing with our borderline patients. The word borderline, as it becomes expanded, now that DSM-3 has included it, is being used by more and more people for more and more kinds of patients than was the case with the analysts of the 40s and 50s, who used it with certain rather fortunate upper-middle-class patients coming for analytic therapy, who are often more depressed than the average depressive neurotic or more cranky than the average whatever, but they were not people who had been kicked around so much when they were young and were a more advantaged group in many ways. And so that the therapy that was appropriate for that group of patients is what you see in the literature, and then you try to apply that therapy to the expanded group of so-called borderline patients as the word borderline expands in its usage. And you end up trying to do treatment with people who have been hideously injured in various ways, humiliated or beaten when they were little, so that the capacity to form a trusting attachment has really been literally beaten out of them. Now, you can't do the kind of things that Robert Knight and various other people were advocating and expect that it's going to go smoothly with such patients. So you have to be aware of limiting factors that limit the amenability to an insight-oriented or exploratory therapy. Some borderlines come to our attention for the first time in an alarming array of symptoms and pathological character traits, yet ultimately have good outcomes. Others, with a less flamboyant clinical picture, emerge as resistant cases who do poorly despite whatever ingenuity and vigor we bring to the treatment process. There are a number of factors that lie outside the realm of diagnostic items per se that contribute to this poor fit between diagnosis and prognosis. One of these concerns maternal love. Mother's love, if we can use this phrase, is a shorthand for the adoring and intense love toward an infant or young child on the part of one consistent and affectionate caretaker, who need not be, but who usually will be, the biological mother, tends to be unconditional, not disappearing in adversity, nor receding apart from a momentary display of annoyance, even if the child is cranky or naughty or demanding. A father's love tends, certainly in traditional home, to be more conditional, in the sense that a child may earn more of father's love and respect by dint of his efforts and performance, and may lose some of it if effort and performance fall too far below father's expectation. Perhaps this combination of influences, mother loves you no matter what, father loves you the more, the harder you try to be good and to excel, conduces to optimal feelings of self-worth based partly on an irrational feeling of being loved under any and all circumstances, and partly on a rational feeling of being appropriately esteemed for one's actual worth in the society at large. While many borderline patients have experienced maternal inconsistency and ambivalence during the phase of separation and individuation, some develop their borderline psychopathology out of a different set of etiological factors. But even where mother was resentful and threatened by her child's burgeoning independence, she need not have been rejecting of the child during the earliest months of life. I suspect the majority of persons to whom we eventually applied the borderline label had in fact been the recipients of a reasonable degree of warm maternal love at the outset, even if this love were to become deformed and overladen with negative emotions 1 or 2 years later. Mother's love under ideal circumstances acts as a buffer against disappointment and hurt, for want of which stressful situations can very quickly become calamitous. To have been raised without mother's love is to inhabit a body that seemingly ought never to have been born, and a person now condemned to take his place in life as a pariah, completely unable to connect in any meaningful fashion with the multitude of ordinary folk who have been humanized by the incorporation of a mother's genuine affection. The normal sense of entitlement, as against the narcissist's excessive feeling of entitlement, the feeling of proper membership in the human community, of justification of one's very existence, are the outgrowths of maternal love. In borderline patients who lack this element, either entirely or excessively, depressive feelings can build quickly into suicidal feelings of the most dangerous sort, heightening the likelihood of death by a serious attempt, rather than merely the stormy life of troubled relationships and suicide gestures characteristic of many less thoroughly unloved borderlines. Serious maternal deprivation cannot be made up for by a therapist. The deficit, having programmed the patient during his formative years, becomes a bottomless pit and leads to a demandingness and a sense of emptiness well beyond the powers of our love and affection, even if bestowed consistently and for several years at a stretch to compensate. Furthermore, the borderline who is a stranger to maternal love lacks the template for this experience and will either not recognize when other people are kindly disposed toward him or will not trust the genuineness of such compassionate interest. Whereas milder feelings of unlovableness and unworthiness can sometimes be resolved in borderline patients whose deprivation was less drastic, those whose supply of mother love was near zero usually remain unable to form gratifying intimate relations of any sort and must be helped to the extent we can reach them at all, therapeutically, to accept a life devoid of intimacy. What I'm contending here is that while mother is the best machine for adapting to the uniqueness and complexity of her child, and in an analogous way the therapist is the best machine for adapting to the patient in his uniqueness, the therapist comes on the scene rather late, sometimes too late, to undo the damage from maternal deprivation, no matter how firm a grasp he has of the psychodynamics, and no matter how much spontaneous, non-sexual love he feels toward his patient. One of the side effects of including borderline in the third revision of the DSM has been to popularize the term as never before and to alter its meaning from the usages implicit in the analytic literature from the 50s and 60s. Suddenly, every difficult patient who is not clearly and chronically delusional becomes borderline. Enthusiastic young therapists often tackle impossible cases, including those where maternal deprivation has been extreme, and thus learn, as learn they must, the borders of treatability. Since it depends upon the skill of the therapist as well as upon the pathology of the patient, this border is more of a zone than a sharp boundary line, and there are still patients that lie well beyond it. I can give an example of a fellow I saw in consultation in New Hampshire. Had been fostered out when he was 3.5 because his parents had 5 kids and they couldn't afford to keep them all. He and his brother were fostered to the same family and were brutalized by the first of several succession of foster parents. Such things as the kid would do some little thing that the foster parents considered naughty. The father would scatter rice on the floor and make this kid kneel on the rice for hours and hours at a time. Okay? One time he had to do a bowel movement and they was locked out of the house and he was running around, trying to find some other way of getting in the house. And in his desperation, he had to dig a hole like a cat would and do his bowel movement in the yard, hoping that a neighbor wouldn't spot him and tell the parent. But naturally, a neighbor spotted him and said, "You know what so-and-so did," at which point he got thrashed to literally within an inch of his life. Now, this kind of thing occurred over and over again. This is his daily fare. And by the time he got to be in his 20s, This non-psychotic fellow was able to marry, had a spotty work history because he was so touchy that he would fly off the handle very easily, terribly afraid that he would kill. He certainly has the dynamics of a murderer, and he fortunately had enough of some kind of inhibition against that he became suicidal when he was very angry, lest he hurt somebody. So he'd go off in the woods and scratch his wrist or do something of that kind. But he was terrified that he would, his wife was pregnant with their second child when I saw him, that he too would have either to kill the child or kill himself or give it into fosterage and bear the guilt of wondering what would happen to that child. And he'd gotten into a big fight several hours before I got there with some other patient in the clinic who kind of crossed his path and looked ugly at him and maybe said an unkind remark of some kind, and he really mopped the floor with this guy. Now, working with someone like that and inviting him to come full face with all of the horrors of the past, and then expect him to trust you as a therapist when what had happened to him with all these people in the early years of his life is expecting too much. It's not likely to happen, and I think one has to be careful about jumping into it, working with somebody who has that sorry history. Now, to end on a more positive note, I have some borderline patients who look pretty poor prognosis when they started out. Here's one who had a pretty gloomy prognosis when she first came. He was too weak to stand up to the wife. This girl became intensely suicidal during the middle part of her adolescence, made suicide gestures with pills that she found in her surgeon father's doctor bag, also abused marijuana, was a bit promiscuous, and the father was one of these very seductive fathers that had carnal knowledge of 3 generations of women in his family. When his mother was dying of uterine cancer, he did a pelvic on her repeatedly. When his wife was pregnant, he would be the one to say, well, now you're dilated so many. When this girl would come home a little bit late from a dance or something when she was 15, he would do a pelvic on her under the pretext of seeing whether she'd done it or not. So that is pretty close to, it's a brand of incestuous experience. This girl was also the butt of the mother's insane jealousy, and the father, caught between wanting to sort of calm the wife down and wanting to be kind to his daughter, would oftentimes, in the heat of the moment, side with the wife, lest he sort of catch it, later on in the evening. So he would end up doing things which are very cruel to the girl. He was too weak to stand up to the wife. Now, this girl was immensely irritable and angry, and had all of the borderline features of DSM. It was very hard to work with the parents because they pulled rank and they wouldn't talk to many of the staff who were trying to work with them in the hospital. We kept her in PI for 2 years. She was symptomatically much better after a few months, but we felt that to let her go back to that home would be to put her through the meat grinder. And so we let her stay. There was nothing better around in the way of halfway houses or other institutions, so we kept her until she would get old enough to go to college. She got into nursing school. Her father, as he was dying, said, when I go, punch a hole through the wall in the dining room, and there's so many $1,000s I've saved for your education. And by God, she did that when the mother wasn't looking. And she got the money, put it in a savings plan. It's an incredible story. And she had the money to go to graduate school, and she's now a surgeon, married and functioning on a very high level. There are these very favorable patients, and the knowledge of them serves to buoy up our spirits when we tend to get discouraged and struggling in this very hard field.
This concludes this program in the ongoing 1986 SK&F Psychiatry Audio Cassette Library Series, Update on Schizophrenia. Featured on this program were Michael H. Stone, M.D., and Christine McGill, M.S.W. This program was recorded on location at the 7th Annual Vail Conference of the Menninger Foundation. SmithKline & French Laboratories sincerely appreciates the cooperation of the Menninger Foundation in the production of this continuing medical education program. The views expressed here are those of the individual physicians. Their participation is not intended as an endorsement of SK&F products. It should not be inferred nor assumed that the participants are expressing the views of SmithKline & French Laboratories or any other manufacturer of pharmaceuticals mentioned. This program was produced by SmithKline & French Laboratories and SK&F Co.